A 35-year-old HIV-positive patient with a CD4 count of 50 cells per millimeter cubed presents with fever, dry cough, and progressive dyspnea. Chest X-ray reveals bilateral interstitial infiltrates. Sputum staining is negative for bacteria and acid-fast bacilli. What is the most appropriate next diagnostic step? A. Empiric corticosteroid therapy. B. Bronchoalveolar lavage for Pneumocystis jirovecii PCR. C. Initiate empirical broad-spectrum antibiotics. D. Serum cryptococcal antigen test. E. Initiate anti-tubercular treatment.
B is correct. This HIV-positive patient with CD4 count less than 200 cells per millimeter cubed, fever, dry cough, and progressive dyspnea, along with bilateral interstitial infiltrates on chest X-ray, strongly suggests Pneumocystis jirovecii pneumonia, PJP, an opportunistic infection common in advanced AIDS. The definitive diagnosis is made by identifying Pneumocystis jirovecii organisms in respiratory specimens obtained by bronchoalveolar lavage, or BAL, or induced sputum using PCR or silver staining techniques. Other options: A. Empiric corticosteroid therapy is indicated only after confirmation of PJP or if oxygenation is known to be impaired, not as an initial diagnostic step. C. Empirical broad-spectrum antibiotics are unnecessary at this point, since bacterial pneumonia is less likely, sputum negative, dry cough, and interstitial pattern. D. Serum cryptococcal antigen test is used for cryptococcal meningitis, not pneumonia. E. Empirical antitubercular therapy is inappropriate as sputum is AFB negative and TB usually shows focal or cavitary lesions, not diffuse interstitial infiltrates.
A 65-year-old man is admitted with confusion and asterixis. Blood tests reveal elevated ammonia, prolonged PT, and low albumin. What is the most appropriate treatment? A. Lactulose administration. B. Intravenous glucose. C. High-protein diet. D. Antibiotics alone. E. Liver transplant immediately.
The most appropriate treatment is A. Lactulose administration. This patient presents with classic signs of hepatic encephalopathy, which occurs due to accumulation of ammonia and other neurotoxins in patients with liver failure, as indicated by prolonged PT and low albumin. Lactulose, a non-absorbable disaccharide, is the first-line therapy because it reduces intestinal ammonia absorption by acidifying the colon and promoting ammonia excretion through the stool. It also acts as a laxative to decrease toxin exposure time in the gut. Other options: B. Intravenous glucose may be used to prevent hypoglycemia in liver failure, but does not treat encephalopathy. C. High-protein diet should be avoided initially, as it increases ammonia production. Instead, moderate protein restriction is advised until mental status improves. D. Antibiotics alone, example rifaximin, may be added if lactulose is insufficient, but they are not first-line therapy by themselves. E. Liver transplant is the definitive treatment for end-stage liver disease, but not an immediate step in acute management of hepatic encephalopathy.
A 45-year-old woman presents with exertional dyspnea and lower limb swelling. Echocardiography shows severe mitral stenosis. What is the most likely cause? A. Rheumatic heart disease. B. Infective endocarditis. C. Congenital valve abnormality. D. Degenerative calcific mitral stenosis. Or E. Drug-induced valvulopathy.
The most likely cause is A. Severe mitral stenosis in a middle-aged woman with exertional dyspnea and peripheral edema is classically due to chronic rheumatic carditis, a sequela of rheumatic fever following Streptococcus pyogenes, group A streptococcal, pharyngitis. Rheumatic inflammation leads to fibrosis, commissural fusion, and calcification of the mitral valve, causing obstruction to left atrial emptying, pulmonary congestion, and right-sided heart failure signs, e.g. leg swelling. Other causes: B. Infective endocarditis, usually causes valvular regurgitation, not isolated stenosis. C. Congenital valve abnormality, rare cause of mitral stenosis, typically presents in childhood or adolescence, not at age 45. D. Degenerative calcific mitrostenosis, seen mostly in the elderly due to age-related calcification, not in middle-aged adults. E. Drug-induced valvulopathy, associated with ergot derivatives, cabergoline, or fenfluramine, and typically causes regurgitant, not stenotic lesions.
A 60-year-old diabetic woman presents with burning epigastric pain relieved by food intake. What is the most likely diagnosis? A. Gastroesophageal reflux disease. B. Gastric ulcer. C. Duodenal ulcer. D. Pancreatitis. E. Cholelithiasis.
The most likely diagnosis is C. Duodenal ulcer. The burning epigastric pain relieved by food intake is the hallmark feature of a duodenal peptic ulcer, most often caused by Helicobacter pylori infection or NSAID use. Pain typically occurs 1 to 3 hours after meals, may awaken the patient at night, and improves temporarily with food or antacids because the meal neutralizes gastric acid. Other options: A. Gastroesophageal reflux disease, or GERD, causes retrosternal burning pain that worsens after meals or when lying down, not relieved by food. B. Gastric ulcer. Typically causes pain that worsens with eating as food stimulates acid secretion over the ulcerated mucosa. D. Pancreatitis. Presents with severe epigastric pain radiating to the back, often associated with vomiting and elevated serum amylase or lipase. E. Cholelithiasis. Causes episodic right upper quadrant pain triggered by fatty meals, not epigastric burning relieved by food.
A 43-year-old man presents with acute onset high fever, chills, and productive cough with rusty sputum. Chest X-ray reveals consolidation in the right lower lobe. What is the most appropriate initial treatment? A. Oral amoxicillin. B. Intravenous vancomycin. C. Oral ciprofloxacin. D. Oral azithromycin. E. No antibiotic, supportive care only.
The most appropriate initial treatment is A. Oral amoxicillin. This patient presents with classic features of community-acquired pneumonia, or CAP, caused most commonly by Streptococcus pneumoniae. For otherwise healthy adults without significant comorbidities, high-dose oral amoxicillin is the first-line empirical therapy recommended. It provides excellent coverage from pneumococcal pneumonia, the most likely etiology in this case. Other options are less appropriate initially. B. Intravenous vancomycin is reserved for suspected MRSA pneumonia or severe hospital-acquired infections. C. Oral ciprofloxacin is ineffective against Streptococcus pneumoniae and not recommended for CAP. D. Oral azithromycin can be used as an alternative, particularly in cases of atypical pneumonia, for example, mycoplasma or chlamydia, or in penicillin-allergic patients. E. Supportive care only would be inappropriate, as bacterial pneumonia requires prompt antibiotic therapy.